Good morning and good afternoon, everyone, and thank you for joining us in our first of a two-part webinar series on policy actions to prevent cancer. My name is Fayed El-Sheikh, and I'm an analyst within the Person-Centered Perspective and Prevention team at the Canadian Partnership Against Cancer. And I'm delighted to be joined today by all of you to discuss HPV immunization in Canada and opportunities for improvement through policy actions. I'm thrilled to be joined by Dr. Jacob Kelly, Director of the Health Ethics Law and Policy Lab at Western University. Dr. Kelly holds joint appointments within the faculties of Law, Health Sciences, and the Rotman Institute of Philosophy. His research in the interface of law, public health, and ethics has informed chronic disease prevention policy, and the work of his team at the Health Lab was pivotal to the development of the HPV immunization for the prevention of cervical cancer report. I'm also joined by my colleague, Benjamin Rempel, who is an analyst within the Person-Centered Perspective and Prevention team at the Partnership, who will be joining us for the discussion portion of this webinar. Before we get started, a few housekeeping announcements. Please note that you may turn on subtitles for this webinar in English or French by selecting the settings button on the bottom right of your screen. All attendees will be muted throughout the duration of the webinar, but you may provide questions that you have in the Q&A section, which can be accessed by pressing the question mark button on the top right of your screen. Following this webinar, a recording and presentation slides will be shared with all attendees and also made available on our website. Lastly, we hope you will join us for the second part of this series on June 22nd, where we'll be discussing policy actions to reduce alcohol-related harms. I'd first like to take this time to recognize the traditional territory on which I'm fortunate to reside. I have the privilege of living on the traditional land of many nations, including the Haudenosaunee, the Anishinaabe, the Attawandaronk, the Mississaugas of the Credit. And this land is also now home to many diverse First Nations, Inuit, and Métis peoples. Like many of us over this past year, I have had the opportunity to reflect on the importance of place and community, and that's given me a new appreciation for this land. And it's also served as a reminder of our individual and collective responsibilities to protect and respect the land and all those who have and continue to call it home. Part of that responsibility is recognizing the legacy of oppression and racism on which many of our institutions were built. The horrific discoveries of 215 Indigenous children found buried in mass graves at the site of the Kamloops Residential School is just the most recent reminder of centuries of injustice faced by Indigenous people in Canada. As we gather today to discuss policies impacting the health of young people, issues of consent, issues of public trust, I encourage you to reflect on how you and the organizations and communities you represent can work to take action to redress these harms through respect, cooperation, and partnership with Indigenous peoples. So for today's webinar, we're excited to see so many attendees joining us from different areas within the health space. This webinar will be light on data and will focus on opportunities for action. We will briefly discuss HPV immunization and its role in the cervical cancer elimination initiative in Canada. We'll touch on immunization programs and their current state. Dr. Shelley will provide an overview of immunization legislation and opportunities for improvements. And we'll have time at the end to answer your questions. So please share those in the Q&A box. For those that are not familiar with the partnership, I'd first like to tell you a bit about who we are and what we do. The Canadian Partnership Against Cancer is an independent organization funded by the federal government to accelerate action on cancer control for all people in Canada. We work closely with the provinces and territories and other partners to promote equitable access to quality cancer care and cancer prevention. As steward of the Canadian Strategy for Cancer Control, our efforts are focused on the long-term objectives of reducing the incidence of cancer, reducing the likelihood of dying from cancer, and improving the quality of life of those affected by cancer. Priority 1 of the strategy, decreasing the risk of people getting cancer, is where HPV immunization lies, primarily within our work on the elimination of cervical cancer. Cervical cancer continues to impact the lives of thousands of people in Canada and hundreds of thousands around the world. Yet it's almost completely preventable, in large part due to HPV immunization. There are 3 key pillars to preventing and treating cervical cancer: HPV immunization, screening, and timely appropriate follow-up. Human papillomavirus, or HPV, is the causative agent for virtually all cervical cancers, and the first vaccines that protect against HPV were introduced in Canada over a decade ago. Since that time, vaccines have already led to significant reductions in the incidence of HPV and cervical precancers here and around the world. And new evidence from a 10-year study out of Sweden, which monitored 1.5 million vaccinated individuals, has now for the first time shown that HPV immunization is associated with substantially reduced risk of invasive cervical cancer at the population level. While the seminar focuses on the impact of HPV immunization and cervical cancer, it is important to note that protection can be provided against other diseases, notably penile, anal, head and neck cancers, and genital warts. The action plan for the elimination of cervical cancer in Canada sets out priorities, targets, and actions for the next decade that will move us toward the goal of eliminating cervical cancer by 2040. The action plan consists of 3 main priorities and corresponding targets. The HPV immunization target is aligned with the Government of Canada's National Immunization Strategy, which has set a goal of 90% vaccination coverage by 17 years of age for 2 or more doses of HPV vaccine by the year 2025. We know that cervical cancer will only be eliminated if everyone in Canada has equitable access to the highest quality prevention and care. Additional targets are included in the action plan to address these present inequities. People's specific priorities and actions are a key component of the action plan, and specific actions are laid out in the action plan for each of these priorities. Accompanying the action plan, the partnership has recently released the HPV Immunization for the Prevention of Cervical Cancer report, This resource, which was released in March, provides up-to-date information on HPV immunization policies and programs in place by jurisdiction, as well as outlining key considerations for underserved populations. The report also includes an overview of legislation relevant to HPV immunization. You can find the report on our website at partnershipagainstcancer.ca, and I encourage you all to take a look at that document to get the in-depth information of the topics we'll just touch on today. The two main ways Canadians access HPV immunization are through publicly funded programs. Publicly funded school-based HPV immunization programs are the primary method for vaccine delivery. These programs have provided an effective means to reach young people and are in place in all provinces and territories. Programs were implemented in 2007 for girls, and by 2017 had been extended to boys in all jurisdictions in Canada. School-based immunization schedules for the HPV vaccine are administered starting in grades 4 to 7. And the HPV vaccine is most effective when it's given during the pre-adolescent years, preferably prior to exposure to HPV. The typical model for school-based immunizations is that they're delivered by public health, usually with public health nurses going into the schools to provide vaccination. School-based programs have been shown to be an efficient way to reach the majority of children and to reduce disparities in access as compared to requiring parents or guardians to seek vaccination for children in clinic or primary care settings. Catch-up programs offer an opportunity for immunization to those who did not receive vaccination through school-based programs or were in school prior to immunization programs being offered. Although vaccination is recommended for adolescents before sexual activity begins, research has shown that the vaccination of young women in catch-up programs is effective for improving herd immunity and reducing risk of invasive cervical cancer. These catch-up vaccinations are publicly funded under the provincial or territorial health plans, but eligibility varies based on age or gender. In addition to catch-up programs for individuals who have not completed the HPV vaccine series under the school-based programs, 4 provinces have extended the eligibility criteria to the HPV vaccine for high-risk groups. While vaccines against HPV have been introduced in Canada for over a decade, we continue to experience challenges in reaching high uptake across the target populations. For example, as you can see here, girls' final dose uptake rates in school-based HPV immunization programs vary considerably across provinces and territories, ranging from 57% to 91% in the latest available data. Wide variation is also observed within jurisdictions. The action plan calls for efforts to increase vaccination uptake in school-based programs across Canada using innovative education and program delivery strategies. As the primary preventative tool against cervical cancer, ensuring the public is adequately educated about HPV vaccination is critical. Lack of information about vaccine benefits is a major barrier to HPV immunization uptake. Focus group data shown here displays the varying factors and judgments behind an individual's choice not to vaccinate themselves or their children. It's been documented that the top barrier to vaccination is the lack of healthcare provider recommendations, according to 38% of Canadians surveyed. This indicates physician partnership, as well as empowering people to inquire about HPV vaccination will be key in the strategy to increase uptake for HPV vaccines. And with that brief background, I'll welcome Dr. Shelley to give us an overview of the legislation landscape as relevant to immunization.
Great, thank you so for that introduction. I'm hearing myself. Not sure make an echo or. Can you hear an echo or are we good? I think I'm not hearing myself now, so whoever's in charge, thank you for fixing that. So thank you so much for having me, and thank you to the partnership for partnering with the Health Lab. I think it's actually really important when we're talking about policy actions that there is an increased kind of involvement of legal scholarship, and there are many fantastic legal scholars across this country who would, I think, be well suited to help kind of make inroads and have discussions around cancer prevention. I also really want to make sure that I thank the team that worked with me, my doctoral student Kurt Tulsrum and my two research assistants Ivy Duong and Taylor Cumpson, who did fantastic work on this project, and without whom I would have been a little bit more lost. They provided much guidance and assistance, so thank you to them. When it comes to legislation, and in a brief overview, it's hard to kind of get into the depths real quick. So really what I wanted to talk about is three kind of overarching groups or bodies of legislation. The first being public health legislation and their corresponding regulations. Every province or territory has public health legislation, usually called the Public Health Act, sometimes called something very different. Ontario, it's our Health Protection and Promotion Act. And this legislation is actually very, very important because one of the things that it actually does is identify vaccines as a preventative measure, and they can be used to actually require certain persons to be vaccinated, or perhaps to preclude them from participating in some activities if they're not vaccinated. The powers here are often very much confined to cases of epidemics or threatened epidemics or emergencies, but nevertheless there is a base, a foundation upon which public health actions can be taken. Very importantly, the legislation also requires for there to be reporting on and monitoring of certain diseases. Presently, HPV is not specifically identified in any jurisdiction as a reportable infection. We know that data actually can matter here. We know that data can actually provide an incentive not only to policymakers, but potentially to practitioners. And one of the things that has come up is one of the barriers sometimes for getting access to care results from people not having recommendations from their healthcare provider. And so information itself can be very powerful here, and the public health legislation within each province can actually be used to require better data collection. There's also an important role for the federal government, who's responsible for certain populations, including Canadian Forces, veterans, inmates, some refugee claimants, and then of course our First Nation and Métis populations, who are under federal purview often, but sometimes slip through the cracks, which is something that we also need to be very mindful of when it comes to jurisdictional responsibilities. So public health legislation and the regulations that correspond with them can be very powerful and important tools. But there's a lot more than that that's going on when we talk about immunization, and undoubtedly many listening today have been involved or in some discussions around vaccination in the last few weeks as we move forward in this country towards overcoming, hopefully, the pandemic. And there are very important rules around healthcare decision-making, rules that provide guidance on who is able to provide consent and when. Now, typically in the common law or in the ethical approach to decision-making in healthcare, common law being how courts look at this, there isn't a magic age. Sometimes legislation actually stipulates an age that must be required. And Quebec is the only jurisdiction which has established that under the age of 14, children have to have parental consent. This is obviously very, very important because we don't have an age for consent. It raises concerns about who actually can consent to the HPV immunization in the first place. And I think there's a general assumption that it's actually a parental decision. But as children get older, and in the age that they'll be receiving the HPV vaccination across the country, typically in roughly grade 7, I have a grade 7 at home actually today learning here. There's this debate about whether or not children of this age can make the decision for themselves. And this is actually really, really important to consider in the context here of delivering a vaccination, because we know that sometimes children aren't getting this vaccine because of the beliefs or perceptions or concerns of parents. And so we have to be sensitive to the fact that this is actually a debate, but there is actually good reason to think that in many instances, children don't actually require parental consent here. Of course, school boards don't like that, and physicians don't like that, and organizations don't like that because it gets murky and complicated. But consent is based on the idea of capacity, and capacity is something that is presumed. And so there actually is a requirement on healthcare providers to assess the capacity of the individual receiving the treatment. A vaccine would count as a treatment. Because it's a bit murky and there are some different views on when a child is actually able to provide consent, the default is often to defer to parental consent. This is something that needs to be thought about in the context of HPV, but also is something that is potentially not going to be a barrier easily overcome in school boards. But nevertheless, it's something to be considered. When a child cannot make a decision on their own part, the responsibility falls to their substitute decision maker. And that's often the parent and or guardian of the child, and then the parent can make the decision on behalf of the child without the child's consent. That being said, substitute decision makers are supposed to make decisions that are in the best interest of the person they're making the decision for. And here, given the overwhelming benefits associated with the vaccine, it'd be hard to make an argument otherwise. So that's kind of in the background with respect to consent in healthcare decision making. We do know that there's also laws across the country that would suggest that requiring immunization is possible. This is a very controversial topic, but for those that live in Ontario and New Brunswick know that there are actual mandatory immunization policies in place for children to attend school. So in Ontario, we have the Immunization of School Peoples Act, and New Brunswick through their Public Health Act. There's actually requirements for immunization for school participation. There's also requirements for a variety of occupations, and some of these are outlined in the document that Fayad had referenced earlier, so you can review. But we know that there are actually occupations where immunizations are required. Mandatory immunization is not likely going to be a winning argument often, particularly in the current context, but it is possible, and not only possible for HPV, but for other things like COVID. And so we will be having this discussion likely as a nation and as provinces moving forward. How about the next slide, Fred? So we know that COVID-19 has obviously had an impact on this discussion generally. So there are some opportunities and some challenges that arise as a result of the pandemic. Very broadly, the opportunities are that we are actually paying a lot more attention to prevention in public health. And so whether it be decision makers or even private industry, we're attuned now to this idea of prevention in a new way. And we also see that there's investment in improving immunization data post-COVID-19, not just for pandemics like COVID-19, but probably more broadly we'll understand the value. We also have seen an increased interest in collecting certain types of data, whether that be based on uptake in certain populations, racialized populations, or populations based on socioeconomic status. And that's actually really important because one of the big kind of pitfalls currently is there isn't standardized data across the country that we can rely on to actually assess what's going on. So COVID-19 has created these new opportunities. We've been talking more about vaccinations as a nation as well, but there's also been a lot of challenges that have arisen. So I mentioned my grade 7 who's upstairs. Well, her opportunity for the school-based HPV immunization program was halted due to school shutdowns. And in many boards and in many schools, these decisions have had to be made in light of the fact that schools simply were not in session. There's also challenges for those that may not have had access or for whatever reason declined or their parents declined to consent to vaccination during their school years, that there's not a lot of access to catch-up programs, and that's been exacerbated during the pandemic when people haven't had access in general to healthcare services. And so what already is a problem has only been further complicated. And then, of course, as we all know, there's been a lot of misinformation that has circulated around the vaccine, around COVID-19, and a lot of hesitancy. Now, that's a challenge and an opportunity, because insofar as there has been hesitancy with these newly developed COVID-19 suite of vaccines, we have had the HPV immunization programs around for a long time. The vaccines have been around for long enough that this actually could also be a jumping off point to say, you may have been hesitant, but look, if it's based on the lack of scientific information or data, look how much data we have. So that can actually be an opportunity to move forward. We also know there's been a lack of centralized information in a registry on HPV immunization, as I've already kind of mentioned. And this data point is actually a very important one for moving forward. Why don't we jump to the next slide? So what are the opportunities right now to increase HPV vaccine uptake? Well, we've identified three here to consider. One is the affordability, that we should actually be making sure these are affordable, particularly for those that are in some provinces where the catch-up programs could be costing over $300. That's a deterrent for many individuals to actually pursue this, and if they don't have private insurance that will cover it, it's an out-of-pocket expense. Given the cost of the cancers associated with HPV, it is a wise investment on the part of the government to actually ensure that these vaccines are publicly funded. We also need to discuss accessibility more. We have to make sure that the vaccine is available to those who didn't have it during school-based programs, or who didn't receive it because of a lack of parental consent, or who may have challenges with actually getting access to service providers who may be able to administer a vaccine. Some of the research we reviewed showed that patients may be reluctant to pursue the vaccine because it was inconvenient to get to the right locations, to get to the service providers to actually get to actually be provided. And then we also need to talk about acceptability. I already mentioned that a strong and clear recommendation from a healthcare professional for vaccination is important. And in fact, the data shows that many are willing to consider a vaccine with that kind of nudging from their healthcare provider. So we need to provide strong and clear recommendations, and we need to train providers and equip them to be able to engage in these conversations, and to do so in a way that is, culturally appropriate. Because in many instances, some of the folks that may be more hesitant may already have mistrust of the healthcare system, or may not fully understand, or may be coming from a context where they don't have the same sort of public health messaging. And so we need to consider the actual experience of those that are receiving vaccines. And this continues into the school-based programs. One of the things that we discovered in our research was that in many instances, children are receiving the vaccine in a very public forum. It's just not a very comfortable environment. And a certain segment of the population is already hesitant to receive needles. And so putting them into a public room or into a gymnasium with their classmates will just further deter. And considering the needs of the recipient, including those that may need to travel or may have cultural or religious sensitivities or objections, and to make it more acceptable and to take the time to explain kind of the benefits of the vaccine. I think in the interest of time, I think I'll stop there to allow more for questions. So back to you, Faye. Or is this my slide as well? I think I'm supposed to do this slide. I apologize for that. I told them I printed everything off, and then I'm not looking at it, so I've just lost my place in my slides. One of the things we actually looked at as well in our work was looking at some of the under-immunized, under-screened, and underserved populations in Canada. And this includes First Nation, Inuit, and Métis individuals. And that's part of the goal, is to try to identify how to increase increase access and acceptability in these populations. And for many of them, including for our First Nation Inuit Métis populations, it's about providing culturally sensitive care. And this may include expanding the types of caregivers who are actually able to provide a vaccination to one that might be more acceptable or connected to a community. We also have already mentioned location and convenience as being an important part of ensuring people get not just vaccinated, but have access to the second dose of the vaccine. And so if it's a 2-dose schedule, we may have an instance where there's a falling off of the second dose simply because of the inconvenience of being able to move forward. And so there are some recommendations about actually having a 1-dose schedule to avoid that kind of falling off of take-up. We also recognize that there are many ways to increase HPV immunization in school-based and youth-focused programs. Our team had surveyed, unscientifically, but we surveyed data out of school boards and schools across the jurisdictions we were examining, and we did see some difference in framing and messaging. Often framing around HPV from more religious-based institutions will talk about abstinence and or monogamy. And so part of it is also to really reassure people that this is not a vaccine that actually increases sexual activity, that the research does not support that, but also that HPV is possible to be transmitted in other ways other than through sexual contact, for example, from mother to child. And that with 70% of the population and upwards having an HPV, whether detected or not, infection at some point in their life, that there's grave concerns that if we narrowly think about how it's transmitted, that might be to our detriment. And we also need to look at solutions or improvements for youth-focused HPV immunization programs. And I think some of these solutions are not always self-evident, but they're simple things, like I mentioned, providing a safe and private space for youth to actually have a vaccine administered, just to make them more comfortable, to make the effort to ensure that they actually have access to an environment that is supportive.
Thank you, Dr. Kelly. I just wanted to close this section by saying that the partnership is supporting work in this area. One of our key ongoing projects fills a unique and complex need not otherwise met in Canada, where little is known about the distribution of current HPV vaccine coverage rates and the proportion of the population that is under-immunized. So this project will look at approaches to increasing HPV immunization within under-immunized populations and will identify and assess interventions and innovative approaches to increase uptake with a focus on addressing inequities. So that's including those experienced by First Nations, Inuit, and Métis, and among youth that do not currently attend school. So with that, I'd like to move us over to the question and answer portion and discussion of the webinar, and I welcome Ben Rempel.
Great, thank you very much, Fayed. And thank you to all of our participants for your active engagement and interest in today's webinar. As part of the registration process, we offered an opportunity for you to ask questions to the presenters. We received about a dozen questions through this process, and we hope to address most of these in the time remaining. Also, feel free to ask questions using the Q&A feature. Some of you have already started to do that, and we will do our best to answer these as the session moves along. So the first question we received several of them themed around the topic area of equity and Indigenous populations. So I'll be asking Jacob first to comment and provide reflections on these first few questions. So Jacob, our first question is around vaccine availability and affordability. And the question we received from our participant is, how can we make vaccines available and affordable for Indigenous populations?
Yeah, it's a great question. I think the easy one, affordable, is that we really need to move towards a publicly funded system, because the changing affordability means that we're somehow changing the socioeconomic status of individuals, and that may not happen. And so, but we really need to focus on ensuring that these are available free of charge. That's only part of the challenge, though, because it's the availability or accessibility, which can mean a variety of things. The ongoing systemic racism and the effects of colonization, the distrust of healthcare providers. It's just, these are large and sometimes feels to be insurmountable kind of tasks. But there are examples of vaccination programs. So one that's mentioned in the report is out of Alberta, which is the Enhancing HPV Vaccination in First Nations Population in Alberta. These kinds of projects have an opportunity to be localized and be community specific, meeting specific community needs in an appropriate manner, and then using intergenerational educators and providers within the communities themselves to help develop materials. So affordability, I think, is easily addressed by just ensuring they're publicly funded. And then the harder part is making sure there's access and making sure that access is culturally appropriate.
That's great. Thanks so much, Jacob. And that goes, in terms of culturally appropriate, that goes right into our next question. A participant asking around cultural safety. So what steps are being taken to ensure policy considers cultural safety and meets the unique needs of Indigenous people?
That's an almost impossible question to answer without looking at specific policies. But what I can say is that there are many folks working within this space that are increasingly recognizing the need to actually to even ask the question. The fact that this question is being asked at all, I think, is a starting point. It's nowhere near enough. We definitely need to move forward to ensure that we're working with communities. And so the steps that really need to be taken are to not assume that there's a step to take. There's not one Indigenous community in Canada. There are communities, and I think the fact of the matter is that it will take some work to partner with these First Nations and Inuit Métis communities, but I think there's evidence to suggest that there's an interest, that there are communities that are open and wanting to participate and wanting to address this, and we have to be, I think, mindful of the barriers that I've already mentioned, but we approach this on a community by community basis and not by a one size fits all approach, because that simply has not worked and will continue to not work.
Great, terrific. And Fayed, I'm going to turn it to you if you had anything to add to this question on cultural safety.
Yeah, thanks, Ben. I think Jacob really captured the complexity of this issue. I'd actually like to provide just maybe an obvious comment on the first question around affordability. Vaccines for children and adolescents are not included in the non-insured health benefits program. And, that is a clear barrier. We know that for other adult vaccines, such as the shingles vaccine, that is now available in that program. And I think we need to look at including HPV vaccines in that program if we want to see young adults that, have aged out of eligibility in their jurisdiction, seeing higher vaccine uptake as well.
Great, thanks so much. Great points. So we have some questions over the Q&A board, and so I'm going to shift gears here and talk a little bit around vaccine hesitancy, vaccine uptake, and ask a few questions around that. So one of the questions that came in here through the Q&A board, and again, I welcome participants to type in their questions, and we'll do our best to get to those. So Jacob, a question for you. One of the things we have learned about COVID-19 is that the messaging for youth has been all wrong. Are we creating messaging for the youth who will receive the vaccine or for their parents? Any comments on that?
So the answer is actually both, because number one, some of the, it depends where you are. Some of the jurisdictions start earlier, and the earlier a vaccination program starts, the younger the children are, the more involved the parent will be. I don't think we could ever assume that this is going to be a child-specific or child-only kind of targeted messaging, because there will still be parents who want to be involved in children that don't demonstrate capacity, or providers that interpret that capacity to not exist. So I think there needs to be both. Really importantly, I think though as well, is that there needs to be an honest discussion, I think, with young people as well about what's happening. And I think sometimes, children are, treated as the subject matter and not a participant. And I think so there is a need to, and certainly we've learned a lot of things to do during COVID, what to do and what not to do, and how we communicate with young people. But we also are seeing in response to COVID that young people are keen, they're eager. And I think if they understood some of the nuances of HPV in a way that we talk to them as responsible for their own health, that we may actually have corresponding kind of uptake. It is a little bit tricky. A lot of school boards talk to kids and parents through newsletters, but whether children are reading the newsletters is not clear. So I think making a concerted effort for both populations is probably the strongest and the best way to move forward.
Okay, great. Thanks so much, Jacob. And along that same lines, a lot coming in around vaccinations and how we can make people more comfortable around them. So the next question is the idea of providing private spaces for students getting vaccinated. Have you seen any examples of this that have been done well? Our current system seems to be now efficient at getting a lot of students immunized at once by having vaccinators all in one large room in a school, for example. So can you comment on that and maybe some of the learnings that have come out of COVID-19 and how that might apply to this issue?
Yeah, this actually was brought to our attention by one of the experts we engaged, that this is not something that came up through our research, which I think is actually maybe speaks to the importance of really talking to those that are with boots on the ground, as it were. From a policy perspective or legislative perspective, from the top looking down, you don't always see the context of what's happening in a particular school board or in a particular school. I don't have clear examples off the top of my head of where it was done well, because we weren't looking at that kind of granularity in these policies when we were doing our research. But we did come across, and again through the expert guidance, that most students are being vaccinated in these kind of more congregate settings, whether it be a library or a gym. And I think that's actually something, we know that privacy is important in kind of strange ways. Students may not care about their privacy online, but this is something that they did care about and have expressed to providers. So I think making effort to ensure that it's, we have things like health and all policies, these kind of ideas, but making it easy for people to access this by making it a comfortable environment will probably go a long way, particularly for that segment of the population that is, relatively terrified or bothered by needles. There's some that are hesitant, not because they don't trust the science, they don't like needles. And so that's an embarrassing thing for a young person to be in a gym with the potential prospect of fainting or being distraught. So unfortunately, I can't speak to specific examples of where it's been done well. But I can note that this has been brought up as a way to increase uptake, is to try to make it more palatable for those that are receiving a vaccine.
Okay, great. Thanks so much, Jacob. We're going to continue on the vaccine hesitancy, vaccine uptake line of questioning. There is a question on national data. I'll get to that one momentarily, but just to stay on this same theme, Jacob, are there legal or ethical issues around an opt-out model for the HPV vaccination? Could this be a strategy to increase vaccinations? Yeah,
so it's interesting. And I've talked about this in the context of many vaccines, whether it be COVID or HPV or otherwise. sometimes the language we use seems to matter to some people. That we opt out, it doesn't seem like it's mandatory, or maybe is more palatable. I haven't seen any data to suggest that one is more effective than the other in a way that's legally permissible or not. I think these are just decisions. Opting out is certainly an approach that's taken in some contexts, but I don't know that it's, I don't know that there's any more permissive, for me legally, it's not much different than requiring, or, it's not much different than a mandatory. And in effect, the Immunization of School Peoples Act has an opt-out provision if you have a philosophical or religious objection to being vaccinated. You just have to go through an education session and so forth. So in effect, we do have opt-out programs that are mandatory. Any mandatory immunization program will have to have accommodations built in for those that either cannot, and there will be some that are unable, and then the question of how far do we go with that do not want to, folks that want to abstain for philosophical reasons. I think from a public policy perspective, and this is my own view, not that of the partnership, I prefer the language of mandatory versus opting out. I think signaling is actually very, very important. That we have a very bifurcated approach right now to preventative measures like vaccinations in society, and I think there's some strong messaging that can come through. This is a mandatory one, but given the not only the benefits in other ways for individuals, but the clear benefit in reducing the deaths, premature deaths through cancer, where a lot of other right now the discussions around vaccines and COVID. A lot of people are uncertain about the overall effects or benefits. In this case, it's pretty clear. I think we have a very strong reason to require. But ethics, we get into ethics, people have different perspectives based on different starting points and values. And so is it ethically justified to do an opt-out? I think it would be. I still would prefer myself a mandatory, but that's just my preference.
Okay, great. Yeah, very complex issue as you mentioned at the outset. We're going to do one more here. I'm going to go back to the questions that we received in advance, just to give those a chance to be addressed. And then we do have a question around data, which I'll ask both you and Fayad to comment on. So a question we received in advance of the webinar, and your last answer started answering it anyways. So just if you can add, are there any recommended strategies to combat vaccine hesitancy and at the same time increase vaccine uptake? So Jacob.
Yeah. This is a problem that we're facing in real time, and what we're learning about it is, number one, it's really important that public health messaging be clear, and to the extent that's possible, that it be consistent, because we have seen some real challenges with some of the variety of messaging coming out about COVID vaccine. Let's put it that way. I think it's also really important that we recognize the power and persuasiveness of misinformation. And that requires those of us that work in these fields or working in schools to really be armed with good information and not be afraid to call misinformation out. I think sometimes we tend to really kind of hesitate to really call it out for what it is. And at the same time, I think we need to be sensitive that people that are vaccine hesitant aren't simply ignorant or uncaring or not interested in community. There may be very legitimate reasons why, and some of them may be predicated on distrust of the healthcare system or previous bad experiences. And so there's a great book on vaccine hesitancy by Maya Goldenberg from the University of Guelph. So there are people that are doing research and realizing that vaccine hesitancy is actually more complicated than simply being anti-science. And so I think taking time to speak with people. But one of the things that we could do to really combat it is to educate those that are at the front lines, the healthcare workers that are actually having a big impact on vaccine uptake, and that who can answer and may be a trusted source of information. And then we also want to make sure that for those communities that may have some trust issues with and legitimate trust issues with the system, with the healthcare system, that we're educating the providers they do trust and rely on, the intergenerational leaders and the the traditional healers and so forth, that they also are part of the discussion and that they're included.
Great, thanks so much, Jacob. Fayed, I'm going to turn to you for the next question, and then Jacob, if you had anything to add after that. It's around data collection. So the question is, what, if any, advancements have been made on developing national centralized data collection?
Yeah, that's a great question, Ben. In terms of a national perspective, I think we're still very far away from something centralized in that sense. But part of the program that I introduced earlier today is really that focus on looking at the jurisdictional, whether that be provincial or territorial data collection processes, as well as inputs, and seeing how we can try to align those across jurisdictions better. And that will be part of that work being led by the Urban Public Health Network. Because, you know, one of our biggest challenges is the lack of good data on who is being vaccinated and who is not. And we know we have poor or non-existent vaccination registries in some settings, or registries that are housed within education but aren't accessible to a patient's healthcare provider. So I think, you know, all of these issues, as well as the lack of identifiers for race, ethnicity, and other important demographic factors, really need to be brought to the forefront and thought about holistically as ways to really improve programming for everyone, not regardless of who they are, but inclusive of who they are and how they receive healthcare.
Okay, great. Thanks so much. Go ahead, Jacob.
Yeah, I'd add to that I think that, you know, we'll see, I think, as part of the answer, but one of the things that will emerge from COVID-19 is that we've had a real-time experience with a disease that has no boundaries, no borders, right? And post-SARS, there was a lot of discussion about communication between the provinces and the federal government, but it wasn't a national issue like COVID has been. So I think by default, we were going to enter into more of a discussion about the appropriateness of that kind of more centralized collection of data and how to use it. And so we ought to be mindful of that and try to, jump in on that discussion around COVID. There are still structural issues in our federal kind of system about who has responsibility and jurisdiction. And so it will require cooperation. But one, maybe naively, one can hope that this recent experience will demonstrate that if we coordinate even just a little bit, we can actually do quite a lot. And in some instances, like with COVID-19, coordination is necessary. Better data is going to be a key part of reaching Canada's goal. And so if Canada is serious about the elimination of cervical cancer, it's going to need to start actually tracking these things better.
Great. Thanks so much, Jacob. Staying on the topic of data and evidence, Fayed, I'm going to turn to you. This is a question we received in advance from a participant. What does the preliminary data on the impact of HPV immunization on cervical cancer rates in Canada suggest, and how is it being evaluated?
Thanks, Ben. That's a great question, and really what we've seen is that since the introduction of HPV immunization programs, there has been a consistent reduction in incidence of HPV and incidence of pre-cancers. However, I really like to bring this back into a holistic approach, especially when we think about cervical cancer. The importance of prevention and immunization, needs to be coupled with screening and appropriate follow-up as well. For those that may have either not have had access or have had access to immunization too late. So I think what we'll see with the targets and priorities set out in the action plan for the elimination of cervical cancer is that we will move more quickly towards those targets of lower incidence of cervical cancer.
Great, thanks so much. We're nearing the end of the webinar. We have about 4 minutes left. So Jacob, I'm going to ask you one last question, and then we'll provide some summary comments and log off. But thank you very much to the participants. I believe we've got through all the questions that came through the Q&A board, and we got through the majority of ones that participants asked ahead of time. So thank you very much for your involvement in that. So Jacob, the last question is around COVID-19. How are policy recommendations related to HPV immunization being revised in light of the learnings of COVID-19?
So I think that I can't speak concretely how they are being revised jurisdiction by jurisdiction, but I think the general approach to immunization, the one thing that is happening is I think we're recognizing, this goes to the question earlier by one of the participants, about the need to actually engage with the kids themselves. And that's happening with COVID-19, that they care about community, they care about their health, they care about being informed. And I think that our approach moving forward in school-based programs is to empower young adults to make good decisions and to inform them. And maybe that also speaks to talking through, catch-up programs that begin earlier and having high school kind of blitzes for talking to students as they get older. Parental consent is no longer as much of a concern. Not that we should ignore the role of parents. I have 4 children. I'm not suggesting that, but that children should be empowered. And I think in light of COVID-19, I think more than ever, my parents' generation talked about getting polio vaccinations because they saw the effects of polio. My generation never saw the effects of not being vaccinated. We took it for granted. I think this generation will see the power and the opportunities that come with vaccination, and I think we ought to utilize that. So I think even if it hasn't yet begun to inform policy or recommendations, we ought to take into account how this generation and the next couple of generations will be impacted by COVID-19, and use that to support and to advance the vaccination narrative.
Great, thanks very much, Jacob. Jacob, I'm going to leave it on you just for 20 seconds if you had any summary comments or summary remarks based on the questions that came up, and then we'll turn it to Fayed for closing remarks.
Yeah, just once again, thank you for all that came and the great questions. And if there's anything else, please Google me, look me up, and send me an email. I'm happy to continue the discussion. I think there's an opportunity in light of COVID-19 to talk about vaccines, particularly those that have been scientifically studied and demonstrated. This is a safe and an effective vaccine. And so even those that may be hesitant given the misinformation or lack of, in their mind, scientific data, those kinds of concerns can be addressed here. So there's an opportunity to use this, that we can prevent the spread of COVID-19, and we can also prevent the untimely and premature deaths and the cancer incidences of many if we simply vaccinate for HPV. So I think we can use that as an opportunity to move forward. Thank you for inviting me to participate today.
Great. Thanks so much, Jacob. Fayed, I'll turn it over to you for closing remarks.
Thanks, Ben. I think for me, really the important thing to reiterate is the importance of public trust when it comes to immunization, and especially immunization of young people. I think it's important that we empower individuals and we tailor our messaging and our communication to meet them where they are, and ensure that we are inviting people into this process. So I'd like to thank Dr. Shelley for joining us today for this great discussion, and I'd like to thank all of you for your great questions and for your attendance today. Please, if you have not already done so, take a look at our report on HPV immunization for the prevention of cervical cancer. And we look forward to seeing you at part 2 of our webinar series on policy actions to prevent cancer, where we'll be discussing policy actions to reduce alcohol-related harms. So with that, I'd like to thank everyone for their time today and wish you all a good afternoon. Thank you.